So again, my name is John. I'm one of the nurse leaders here. I'm also a student at Ramapo, and one of my assignments is to have a presentation for new nurses. And so the topic that I chose is nasotracheal suctioning in pediatrics. And one of the big reasons why I picked this presentation or picked this topic for this presentation is because I feel like it's a common task we all do as pediatric nurses. And it's so something that I want you guys to ingrain into your hands and develop that confidence in a comfortable space. A lot of the times I think nursing students are thrown into a task without practicing it beforehand. And so a lot of your skill set is based on just practice, right? Getting the confidence to do something in your hands versus just reading it in a textbook. So I want you guys to go over this, but also be in a comfortable space to learn, to be corrected, for us to remediate if something feels off. Just ask, how do I hold this correctly? Because again, a lot of it is fine motor skills and also having that cognitive foundation to back up what you're doing. All right, so our three sections of our objectives, the three areas I wanted to go over is the cognitive domain, the psychomotor domain, and the affective domain. Basically, these are kind of those three domains of learning that are a process. You have that foundation as a cognitive foundation, and then you go into the psychomotor domain, which is when you apply those skills, that knowledge, into your hands-on dexterity. And then when it goes into the affective domain, that's how you build that confidence. That's how you feel after, whether you really assessed yourself and have that self-reflection on if this is a task that I've accomplished well or not, or something that I continue to work on. Okay? So in the cognitive domain, some things we want to focus on is recognizing the signs and symptoms of respiratory distress is at its foundation, right? We want to see, when do I need to suction? When I see a patient and I see there's some levels of respiratory distress, this is when I know I need to intervene. Understanding the appropriate catheter size, it's a little bit more of that's easier to understand because you just really go by age and then pick the catheter you want. But there's still some processes going on there in terms of learning. And then we also want to evaluate the appropriate techniques for pediatric patients. Pediatric patients are very particular, right? So they have different anatomy, they have different needs. So just understanding what specific pediatric stuff you need to know before going into this procedure. Now going into the psychomotor domain, I want you guys to acknowledge and obtain the accurate supplies. So that's part of that dexterity of it all. When you have a patient that needs to be suctioned, you want to be mindful of, I need to grab these things, right? That's a task that you need to do with your hands. So being prepared for that and just knowing what you need to grab. Also practice safety standards such as sterile or clean technique based on your facility needs. And then directly applying that knowledge to the motor skills, right? And then lastly, like I mentioned, is the affective domain. So here we want to practice awareness to the patient needs and the environment. And so again, this is that mindfulness part of the learning. Organizing your skills and knowledge to understand your own practice and implementing motor practice of skill to develop confidence. Again, these are the feelings that you have when it comes to these tasks. Am I building up enough confidence? Do I feel like I've done, I'm going in with a little bit of apprehension? Do I need assistance? That's a part of the learning as well. So what is nasotracheal suctioning? Can you guys just give me a few words of what you think it is? I know the definition's right there, but just any thoughts. What is suctioning?
Removing secretions.
So done. And why do you think we need to remove secretions from the patient? Maintain a patent airway, right? So what physiological processes, what could they be sick with? Upper respiratory stuff, good. So things that might cause a buildup of secretions that you want to just take out, right? By definition, it's the process of removing secretions from the child's trachea or bronchi by inserting a flexible catheter through the nose. It additionally stimulates the cough reflex to help remove secretions and irritants from the airway. So already from that definition, when you apply that to pediatrics, inserting a flexible catheter into a patient's nose, can you already see what hurdles you might come across? Kids are not going to like that, right? So as soon as you insert that, you're going to need some help. Things like that you have to consider, right? And also stimulates the cough reflex. So that cough gag reflex when something goes down your throat, also an uncomfortable experience, right? So things, again, you want to be mindful of that in addition to completing this task, you're also mindful of the patient's comfort and the parents that are watching you. So many variables are happening at that time that you really have to have almost laser focus to the task that you need to do, but in addition, mindfulness of your surroundings. So that's why it seems like a simple task, but once you get like the confidence, that almost becomes second nature, and everything else you could be very mindful of to do those and address those issues while you're suctioning at the same time. All right, so why do we suction? I have this little picture of a very wide water slide and one that's a little more turbulent, a little bit more skinnier, right? What are the differences between these two water slides?
There's less water here.
Less water here. Are they chilling? Are they going through this water slide pretty easy going? And this one's a little bit more rush, right? They seem there's a little bit more going on over there. One of the best analogies I got about patients' airways, and in particular pediatrics, is that just think of it as a water slide, right? There's a lot more flow that easily can happen when there's not that much of stuffiness in there, right? Imagine just breathing yourself in and out. You guys hopefully aren't sick and you could breathe more easily, but when there's stuff along the way, it's harder to breathe, right? And so everything starts working towards that goal of getting the oxygen in and the carbon dioxide out, right? And so if there's stuff along the way that's hindering that, then it's harder for the kids, and you'll start to see physiologically things that are happening to them, whether it's like head bobbing, tracheal tugging, nasal flaring, their retractions. The more muscles are being used to get this goal done, right? As opposed to you just sitting there, a lot more easier. So things to think about when kids are breathing and they're sick. Listing off some benefits here, like you guys mentioned, so it helps maintain a patent airway, it promotes optimal exchange of oxygen and carbon dioxide, helps prevent pneumonia, especially when those secretions can pool in the lungs, and that's like a breeding ground for more infection. Perform when signs of respiratory distress or hypoxia are present. It helps patients who are unable to cough effectively, especially for patients who might be on the sleepier end, maybe they're like post sedation, and so their cough and gag are a little bit weaker. So those are times maybe they need a little bit of suction, need a little more support from us. And it could also help remove blood, vomit, or other foreign materials. All right, so in front of you, you guys have a copy of the respiratory severity score. Take a quick look at that, because that's one of our ways of finding respiratory distress in our patients, right? If you can see going from left to right, you start with normal, right? Normal presentation, so the respirations are in normal range. Our SpO2 in room air is 96% or greater. When you auscultate, when you listen to the patient, they're either clear, no crackles or wheezing, and then retractions, none, right? But as you move towards the right, you start to see the severity increase. Whether in that top section, you start gaining some points when the respirations are going higher than what the normals are, right? And then when you go into the section for the pulse ox on room air, those numbers, those goals are starting to get a little bit lower, where to the point where you want to get 3 points on your scale, your patient has to present with less than 90% on room air. So already that should be like an antenna for you guys to be like, something's off, right? If they can't adequately oxygenate and they're going less than 90 on room air, they need some oxygen support already, right? Going down, auscultation, it goes from clear to starting to have some more expiratory crackles and wheezing, and then by the 2 points, you're already having wheezing throughout the expiratory phase, and then by the 3 pointers, you really work looking at things that are indicative of respiratory distress. So they have inspiratory and expiratory wheezing, they might have diminished breath sounds, minimal air movement. Those again are your antennas and your red flags that something's off, like the air that should be going through their lungs is not doing what it's supposed to do, right? And then retractions, this is the sign for you to see their effort. So let's go from left to right. You have no retractions, and then 1 pointers, you have the subcostal or intercostal. So as you can see, different sections of the ribs are starting to work. So it's either one of those, and then by the 2 points, now you have subcostal and intercostal, or any of the two, or nasal flaring. So at this point, now you start to see some nasal flaring, which means it's starting to work up. Right now they have to use their nose to breathe more. At baseline, your nose is not really doing like extra muscle effort, but for kids, you can actually see their nose flaring. And then by the 3 point, you have 3 of the following, either subcostal, substernal, intercostal, suprasternal, and supraclavicular. or nasal flaring and head bobbing. So head bobbing is a really, again, that red flag is going up, that it's starting to work their entire body just to breathe, right? So, yeah, and then also if you're using 3 of those rib muscles, 3 sections of that, then you're really starting to work your entire torso. So keep that in mind because we're going to go through some case studies. But before that, quick question, based on the respiratory severity score, what physical presentation of respiratory distress automatically adds 3 points? So you have A, head bobbing, B, diminished breath sounds, C, SpO2 less than 90% on room air, D, inspiratory and expiratory wheezing, or E, all of the above. E, right? The reason why it's a pretty straightforward question, but why I wanted to bring it up is because these are the 4 things in your head automatically, I should be concerned about my patient, right? If you see any of those, you should have some kind of inkling of something's off and I either need to intervene or let the physicians know, right? And that's where your first go-to, one of the first moves is suctioning. So any of these things, especially if they start to pull and you physically can see the secretions, go in and suction your patient. I think a lot of time as nurses we get comfortable that we think kids can compensate, but kids can go so quickly with their respiratory status that you want to intervene earlier than later. All right, let's look at case study number 1. I'll read it slowly so you guys can get a full picture, and then we can reread it again and really analyze it. So, and again, you're going to use the respiratory severity score in conjunction with this case study. So pretend it's really a patient. There's a 3-year-old who presents to the ED with shortness of breath. You know she is breathing about 50 times per minute, has intercostal contractions, and inspiratory and expiratory wheezing. And feel free, you could destroy the paper, like really circle and put points to this patient. She has no appetite despite not eating in the past 6 hours. Here are the following vital signs. Respiratory rate of 50 breaths per minute. O2 sat is 94% on room air. Heart rate 134. Blood pressure 101/64. Temperature 98.5. So let's break it down slowly. In order to get this respiratory severity score, we're going to first go on the top. How fast are we breathing? 50. And then, so what points do we get for a 3-year-old breathing 50? 3 points. All right, so we already have off the bat 3 points. Now again, we're looking now at SpO2 on room air is 94%. What points does that get us? 1 point. Nice. So now we're at a total of 4. What else are we looking at? Auscultation. So now we listen to the patient and we hear inspiratory and expiratory wheezing. 3. And this one is a particularly important one because a lot of time auscultation can be subjective, right? You think you heard something, maybe it's just an expiratory, maybe it's just an inspiratory, but in this case, you can clearly hear it. Sometimes if it's like a mild, hoarse one, that's probably on the lower end of like a 1 or 2, but if you can clearly hear it, inspiratory and expiratory, or diminished breath sounds, or minimal air movement, those are the type of things that have to score higher. And then lastly, we have retractions. Our patient is noted to have intercostal retractions, and that is 1 point, right? So what's our total at the end?
8.
Nicely done. We have a score of 8. So now what does that score mean? Sometimes when we chart stuff in Epic, like we put it in and it doesn't tell us what it wants us to do. So just be mindful of like, yes, I need to know the total, but I need to know what that total means. What intervention do I need to do? And so now we see 7 to 8. In between that scale, we're at in moderate respiratory severity. Based on the algorithm that you use, we have a specific high flow one that we're going to use to like initiate high flow or initiate like suctioning. These are the type of things you have to just think about. All right, case study number 2. Now we have a video. So a 1-year-old on the pediatric unit presents with the following presentation. He has head bobbing, is drowsy and lethargic, has diminished breath sounds, and he has pushed his bottle away for the past 5 hours. What is the patient's respiratory severity score? I'm going to play the video, but I want you guys to be paying attention because what is not included in the description that you need to know? Respirations. So we're going to count. I'm going to give you a little clue. This video is 12 seconds long. So just, do you guys have timers on you? You have your phones? Get those ready. And then, or either look at a clock. And I'll play it a few times if you need to.
Poor Bubba.
I know. I'll play it one more time. You might have to do some math. There's about 12 seconds. I'm gonna do it one more time just so you guys can confirm. It doesn't hurt to double check yourselves, right? What's our respirations per minute? 60, okay. And then what does our scoring system tell us? For a 1-year-old? 3 points. All right, and then what else does the case study tell us? He has head bobbing, is drowsy and lethargic, and has diminished breath sounds. We have diminished breath sounds. What score is that? 3. We have head bobbing. What score is that? 3. And then I believe we were on, did I tell you SpO2? Let's say it was 89 up in there. 3. So score of 12. So this patient is really trying to compensate, right? At this point, it's like a total head-to-toe presentation, to the point where literally they're head bobbing. I know you didn't see in the video, but literally the patient's head is going like this. Probably can see some tracheal tugging as well, some flaring going on. Especially at that rate, you really see the muscles going too, right? That should be, again, those attendants going, I need to do something about this patient. Whether it's the oxygen, whether it's the suctioning, your algorithm or whatever interventions, they're gonna tell you what to do. But at baseline, you should know, like, hey, suctioning, antipyretics, maybe he has a fever, right? Things you have to look out for, maybe repositioning. All right, so now let's go into the actual suctioning part. I'm listing off some equipment just so you have it. You have a resource for that. Basically what you need, I'll just list it off really quick. You have your wall suction, everything set up over there. You have your suction canister, your suction tubing. You're gonna pick the size of your suction catheter based on the age. Sometimes you could have a Yankow or a little sucker, which is like just bigger apparatus to get secretions. PPE, gloves and masks, stethoscope, normal saline solution or sterile water, normal saline drops, just to lubricate the nares, sheet to wrap the child in case you have a wild 2-year-old or infant. You could wrap them around, get some assistance. Monitor and pulse ox in case you need any kind of like vitals while you're doing your procedure. And then if indicated, oxygen delivery device. Sometimes these kids are already in some low flow already, so you should have oxygen ready for them. All right, real quickly, I'll explain the procedure and then we're gonna get our hands ready, okay? This is pre-procedure setup. Again, why I'm listing this off, because I want you guys to have it in your mind that you should prepare the environment before you jump in. Sometimes, like, you have a kid who's already in respiratory distress, and if you don't have your stuff set up, guess what? That's another 2 to 5 minutes of getting everything. So part of the reason why we do these kinds of teaching is so that you have the room prepared if something like this happens. So pre-procedure setup, you're gonna have perform hand hygiene. You're gonna confirm your patient with 2 identifiers. Clearly explain the procedure to the child and the family. Sometimes this is a quick thing because the kid's already breathing fast. So just even giving them the heads up, hey mom, we're grabbing some stuff, some supplies, just to get some secretions out of the patient. Even something as simple as that, we'll hold them down a little bit, wrap them around, make sure they're nice and comfortable. Things like that, if you just do it, sometimes they're like, what's going on? And you're coming in strong. So a little explanation does even something. Place the child in supine position or sitting on a caregiver's lap, especially whatever they're most comfortable with. To avoid injury to the child, young children should be wrapped in a sheet, and an assistant nurse asked to hold the child's head or extremities throughout the procedure. Initially clean the child's nose with a cotton wool or tissue just to have them blow their nose, especially if they're old enough. You're going to choose the size of the catheter and adjust the pressure depending on the child's age. Then you're going to connect everything. You're going to connect the wall suction, the canister, the tubing, the catheter itself, and have it ready at bedside. I'll show you guys how to actually turn on the suction because you have to include the suction valve for that. You're gonna dip the catheter into saline solution just to test the suctioning really quick, and then lubricate the suction tip while with the lubricating jelly to facilitate passage of catheter. Again, you want to avoid local trauma, especially as the catheter goes into the nose, because the majority of the time, or a good amount of the time, we see some bleeding, especially if you don't use any kind of lubricant. It's very uncomfortable for the patient. Here's a little table to describe what size catheter you need based on the patient's age. You also have that in your handout sheets. So if they're 1 to 12 months, you're just going to use a 6 French, and your pressure of your suction pump, which again you can adjust on the wall, is 80 to 100. If you have a child that is 1 to 10 years old, you're going to use the 8 French catheter, and then your pressure on that is 100 to 120. And then if you're greater than 10 years old, you're going to use a 10 French catheter, and then you're going to go push up your suction 120 to 150. Things to be mindful of this. I know there's a lot of like numbers and whatnot, but essentially you want to think, let's make it comfortable for the patient, right? So if it's 1 to 10-year-old 8 French, but you're putting your suction on blast, it's probably going to scare them, might cause some local trauma, things you have to consider when you make sure you follow the guidelines. And then we're going to we'll go over this when we actually do the skill, but I just wanted to review it before we go in. So step-by-step procedure, we're going to instill 1 to 2 drops of sterile saline into each nostril. Unless they're already kind of really gunky, then it really is just to lubricate the secretions and help it come out more easily. Without applying suction just yet, you're going to insert the catheter into the child's nostril along the posterior pharyngeal wall. All right. A lot of times you might see with your skills sign-off that you might need to do sterile technique. It's facility dependent. So a lot of time you might see it coiled around their hand. That's one technique that you could have with it. You could have it all coiled in your hand and then slowly push the catheter in. I'll show you guys. Advance the catheter quickly but cautiously until resistance is met or a cough is elicited. So essentially when that cough is elicited, that's when you know that that patient is ready to bring up some secretions. You won't always get it because sometimes it could just be very superficial and you just need to grab whatever around there. But essentially that's kind of your like go-to sign that I'm ready to get some good stuff out when you hear that cough. Quick note that quickly but cautiously, you want to go in efficiently, but not too slow because you're just going to prolong their torture. But then also cautiously just to avoid local trauma. That's why it's really fine balance to not hurt the patient, but go in as quickly as possible, get the stuff out, and then you're done. Okay? Now you're gonna, at that point, you're gonna apply suction by placing your thumb over the suction valve, which I'll show you. Using a rotating movement, collect the secretions by slowly pulling out the tube. Do not push the tube forward while aspirating, as this increases the risk of local trauma. So when you're pulling it out, you're really moving your hands slowly, so you kind of get all sides of the wall. So like you'll just essentially see that the hand is going out in a rotation motion. Never suction for more than 10 seconds at a time per nostril. So go, and then we don't even go like at 10 seconds. Sometimes we go like maybe a few, 5 to 8, because we know how much it hurts the kid. And then assess the secretions for their amount, color, and consistency. Amount is a good one because you want to report that back to the physician if it was a lot. Color, if it's more clearer, they might not be as sick, or maybe it's just like a buildup of secretions. But if it's starting into that yellow-green color, you're starting to work with an infection at that point. And then consistency, thinner is okay. I mean, sometimes it depends on the patient, but when you get thicker, I think that's when you get a little bit more of those sicker kids, and it's harder to get out. Once they're starting to improve, you'll see that less secretions are coming out. It's a little bit thinner, a little easier to get out. But again, thinner is not always the best too, because sometimes if it's thin and it's just pooling, it's not a good sign either. But it's really satisfying just getting all that stuff out for sure. Repeat the procedure for the other nostril. And then the procedure should not be attempted personally more than 2 times per nostril. Sometimes it's nursing dependent, sometimes it's facility dependent. I know people haven't just done like more than 3 from my other own experience. And then you're going to stop the procedure immediately if the respiratory distress, if you see any respiratory distress, if there's any profuse sweating, nausea, vomiting, or a mental status change occurs. Especially if you're suctioning and the patient vomits, you're worried about aspirating, right? It going back to the patient. And then you're going to auscultate the patient's breath sounds and assess their respiratory status and effort. All right. So again, you want to do a post-assessment. You did your intervention. Did it actually do something? Let's listen and auscultate and see if it helped. Sometimes the patient's still kind of chilling out a little bit. That's okay. And then you could go back and auscultate once the patient's feeling a little better. All right. And then really quickly, I just wanted to show you, I'll show you in live as well, including the suction valve to apply suction is really just putting your thumb on that little circle part, that little valve, and that turns it on. So at least some nurses have different techniques. Some nurses hold it the whole time. Other people do a little on and off procedure or technique. So it's up to you. I don't think there's any particular guidelines for that. And now it's simulation time. So who wants to try?